Hello, my name is Durairas Prabhakaran. I'm a cardiologist and epidemiologist from India. I'm currently Vice President Research and Policy at the Public Health Foundation of India. I'm going to talk on this important topic of ethnicity, race, and hypertension. So the question is, how does ethnicity and race impact hypertension? The issue is prevalence, treatment, and control rates vary significantly according to ethnicity, and most people would think that it's because of genetic differences, but there are several other factors that contribute to these differences, which include contextual and cultural practices, particularly in relation to lifestyle and socioeconomic status differences, in terms of healthy behaviors such as healthy diet, moderate alcohol consumption, and increased physical activity. The third factor that impacts management of hypertension is the access to health system. How accessible is the health system to people? Is there universal health coverage? Is there insurance for OPD practices? So on and so forth. The last point, of course, is particularly relevant to rural areas and low middle income country settings, is availability and distribution of essential drugs. We know that treatment of hypertension is simple, but these drugs should be available, and it's not available in all the places at all the time. So let's look at two ethnic differences. The first one is people of African descent. We all know that they have a very high risk for hypertension, and when they have hypertension, there's increased risk for organ damage at much younger ages. They have resistance and nighttime hypertension. There's no nocturnal dipping observed as much as what we see in Caucasian population. There's increased risk of kidney disease, stroke, heart failure, and hypertension-related mortality. So the reasons adduced are many, but mostly it is related to physiological differences, particularly the decreased renin-angiotensin aldosterone system, altered renal sodium handling, increased cardiovascular reactivity, and early vascular aging. So what do we do about this, particularly in terms of management of hypertension? The screening is similar. There should be an annual screening for adults more than 18 years. Lifestyle modification should be advised, particularly in terms of health promotion for people who have not progressed on to pre-hypertension or hypertension. And the first line pharmacological therapies should be a single pill combination, such as a thiazide-like diuretic and a calcium channel blocker, or a calcium channel blocker and an angiotensin receptor blocker. Angiotensin receptor blockers are preferred over ACE inhibitors among black patients because there is almost 3 times higher chances of angioedema with ACE inhibitors. Now, let's look at another ethnic population, that is populations from Asia. They are unique in the sense that morning and nighttime hypertension is high as compared to Europeans, and particularly amongst the East Asian population, such as the Japanese, Indonesians, Malaysians, and others, there's increased likelihood of salt sensitivity. In addition to mild obesity in hypertensive patients, there is increased stroke prevalence, especially hemorrhagic stroke, and non-ischemic heart failure as compared to Western populations. In terms of South Asian populations where I come from, particularly the countries of India, Pakistan, Bangladesh, Nepal, Bhutan, and others, the so-called Indian subcontinent, there is increased risk for cardiovascular and metabolic diseases, particularly coronary artery disease and type 2 diabetes. Management of hypertension remains the same, standard treatment until we get more evidence. In fact, we are embarking on a large trial in South Asia to look at um, what are the best drugs for initiation in the management of hypertension. Thank you.